My name's Nicky Stamp. As you can see, I'm a cardiothoracic surgeon here in Sydney, and I want to start by saying thank you all very much for inviting me to speak here today. I have a lot of opinions and I tend to give them freely, but it's not that common that someone actually asks for them, so thank you for breaking with tradition. So I'm going to be talking today about two topics. The first being doctor health and wellbeing, and the second is the pathway after qualification as a specialist. We've got a problem. Okay. Now I am denied about including this in my talk, but I want to give some background as to why doctor health and wellbeing is so personal and important to me. First of all, it's a reflection on my own struggles with depression and anxiety during my training, during my surgical training, and how I thought that was not handled so well. But the second is this is my very dear friend who passed away last year. He was a surgical registrar and he had a very, very difficult battle with depression, and we tried so hard to help him and it didn't work. He was failed by our profession and he was failed by us as individuals. After he died, we all made a commitment to do better, to improve things for doctors. So that's why I'm here today. So moving on, let's get into some data so I can compose myself. In 2013, our national mental health body, Beyond Blue, released this very, very concerning document into the mental health of doctors. It demonstrated that doctors are significantly more likely to have high levels of depression and psychological distress when compared with the general community and other professionals. And that's really interesting because education is normally protective against mental illness. What's really worrying about this data in the second graph there is that the level of suicidal ideation by doctors in the preceding 12 months was up to a third, with female doctors being at higher risk. And that should be a real worry for us all. We have access and knowledge to highly lethal forms of suicide, so we should be really concerned about this. Other studies have found similarly concerning data, including high levels of alcohol dependence, with a quarter of surgeons reporting symptoms consistent with that during other studies. So there are some really significant barriers to health and health-seeking behaviour, and I'm sure we are all very familiar with some or all of these. We're all very time poor. We make our own health quite a low priority, or not making time at all for anything that is vaguely healthy. We don't see our GP, or if things get tough, we don't make time to see a therapist. Stigma, just like in the general community, is also a really strong detractor from asking for help in medicine. Medicine is an extremely insular community, and everyone knows everybody else's business, and we're very quick and willing to pass judgment. This has actually quite a few significant implications, considering we rely on our colleagues and their impression of us to provide us with employment or training positions, or in the case of private practice, referrals. Several years ago, mandatory reporting was introduced to Australia by APRA, and when this happened in Western Australia, the number of calls to doctors' health lines dropped dramatically. And finally, medicine has a potentially damaging culture where we value toughness and sleep deprivation over our own humanity. And as a cardiac surgeon, I'm very familiar with the latter. It was a culture that we picked up last year in relation to bullying investigations by the College of Surgeons here in Australia. So, solutions. I want to state very clearly that despite the presence of all this data and policies by colleges and AMAs and all these other well-regarded bodies, I think for the most part there is a real disconnect between policy and actions. We don't have that many actual programs in order to help doctors. A large amount of the push for improving care for doctors is actually coming from our junior doctors. And if we're honest, these are a very vulnerable portion of our population, of our medical profession. They shouldn't be the one asking for help. They are so concerned about jobs and training positions, yet they're the ones having to stick their hands up and try and drive change. This is a cause that needs to be championed by seniors and our medical leaders. Encouraging healthy and health-seeking behaviours has got to become a priority. This will also encourage early asking for help and arm us to be healthier and more resilient doctors, which can alleviate some of the psychological distress that we encounter and make us much, much better at our jobs. I was driving through the city last week and I saw the lunchtime running groups that run through the Domain here in all their corporate shirts, and I thought that would be such a fantastic idea. I mean, it's obviously a little bit more difficult for us to pop out for a quick run at lunchtime, but there is no reason why we can't have programs like this in our hospitals. As doctors, we also define ourselves very much by our professions, so periods of not working can be quite detrimental to your well-being and sense of self. A supported back-to-work program or keep working program can help doctors maintain a sense of identity and productivity. I have a young friend who had very severe depression last year, and she had her hospital design a graded work program for her where she was supported and supervised. But this only happened because her father was a very senior clinician in that hospital. That shouldn't be something that is only allowed because of who you're related to. That should be a standard. As we saw from RAC's work on bullying last year, we are in desperate need of a culture change. Moving away from rewarding exhaustion or bad behaviours, potentially damaging rostering may improve our health. And as Julian already mentioned, that's an ongoing battle in the UK at the moment with the junior doctors' battle against the health secretary. Now, I've listed a pub at the bottom of this slide, not because I'm Australian and I can't make it through a talk without mentioning beer, but I spent most of my training in Western Australia, that's where I'm from, and our hospital had a hospital bar where we all would go to on a Friday evening, and it was doctors, orderlies, nurses, everybody, and we had $2 Coronas, and it was a fantastic time. We got to team build and meet other people and debrief, and it actually resulted in a much happier workplace, I believe, because I haven't had anything like that since. I actually met my husband there, so that was also a nice side effect. There's a couple of promising small programs that I found in my research, but I think these are scratching the surface and we can do better, but they're such good ideas. So first of all, on the top left is a news article where the NHS, and I'm going to be healthily sceptical about this one, but there are going to be financial rewards to hospitals who instigate programs to improve staff health to try and alleviate the huge sick leave bill that comes from manual handling injuries or from mental health or mental illness. In Stanford, in the US, after the suicide of a vascular resident, their surgical training program started doing games and team building exercises in order to boost the morale of surgical trainees, and this has been extremely well received. Last year here in Australia, the College of Surgeons partnered with Converge International to provide 24/7 access to counselling for fellows, trainees and international medical graduates, both face-to-face and online. And obviously that can have a huge benefit in alleviating this time-poor excuse that we love using. And finally, into the future, online and social media-driven groups and campaigns such as I Look Like a Surgeon, which I'm very heavily involved in, allow formation of strong support networks and mentoring opportunities for surgeons, particularly women who often have a paucity of similar mentors in their location. As I said, we have a really long way to go, I believe. Policy is fine, but it's just not good enough to handle what's becoming a very serious epidemic in medicine. Now, moving on to our second topic, and I'm sorry that we're rushing through this, it's a lot to cover. What happens to our newly qualified specialists in terms of employment? Anecdotally here at least, we're hearing that getting a position after you qualify is increasingly hard. And I recently heard that there were 20-something applicants interviewing for a part-time anaesthetic job in a peripheral hospital. Lots of people are doing multiple fellowships and really struggling to find public appointments. As usual, the Canadians are ahead of us all. This is an excellent study, which I highly recommend you all read, from the Royal College, looking into underemployment and unemployment from new specialists. And their study demonstrated that 16% of new specialists are unemployed, and a third undertake extra training to be employable, not to upskill, to be employable. Procedural specialties are most likely to be affected by this, as they require hospitals to commit finances for facilities and instruments. Running an operating theatre is not a cheap exercise. There's growing concern in Australia that we're going to end up with too many doctors as the government continually increases medical school numbers to meet maldistribution concerns, especially with regards to rural health. Health Workforce Australia predicted that this year in 2016 we would have too many doctors for the number of training positions available, and in my specialty surgery at the time of the report the numbers of surgeons were appropriate, so increasing numbers of surgeons would lead to oversupply in the same time frame. The causes flagged by the Canadian study are numerous, and I suspect we can probably apply a lot of these here. As I alluded to earlier, we are increasing our doctor numbers constantly. Intern positions are increasingly hard to allocate, and we're sticking these new doctors in every nook and cranny of the hospital. When I was a general surgical intern, I was on my own, and now there are 4 of them. Registrars play a vital role in our hospitals, yet we're running a kind of pyramid scheme where their employment prospects at the end of their apprenticeship time are actually a little shaky. Career counselling for our new or prospective trainees doesn't take into account these factors, and while we're very good at telling them about what the job actually entails, we can't quite articulate what it's going to be like in terms of finding employment. I was actually at a cardiac surgical conference yesterday, so it's a slightly different atmosphere here to there. And we were talking about how our training programs need to evolve. And one thing that struck me is that they need to evolve rapidly, because that's what's happening in our profession. Our procedures and our way of care is evolving rapidly, so we need to be ready to respond with regards to training. Workforce planning is also a small problem. I think this is a really, really difficult task, and I wouldn't dare try and emulate this kind of difficult procedure. But surgical workforce planning, for instance, is done assuming those older than 55 will retire, which is no longer true for anybody in our population. So first of all, I want to ask you all, is this a problem? Should we care? Do we have a responsibility to our trained specialists? I actually think the answer is yes. We are risking a huge brain drain and loss of what is an excellent, highly trained and expensive resource. It costs $903,000 a year to train a surgeon in this country, not foregoing your own personal financial and other expenses. If, like me, I have no employment now, I'm an expensive investment de-skilling. I'm changing my practice. I'm going to undertake more training, and I'm actually leaving the country later on this year because the work is much better overseas. With the healthcare dollar stretched more than ever, we actually have a fiscal responsibility to our taxpayers. If we've wasted this money on all these highly qualified specialists who are sitting around doing nothing or not working to their full potential, it's actually a bit irresponsible. In Australia, we need a lot more data, and I feel terrible mentioning that after our previous speaker. Good data. Workforce data that we do have, or that I've been able to find, is actually a little bit of a blunt instrument that doesn't pick up the finer points of this issue. First of all, though, as I mentioned, workforce planning probably needs to be closely looked at because our retirement age is changing. In the case of surgeons, again, surgeons over the age of 65, 3/4 of them do the work because they love it, and they are not going to go anywhere if that's the case. As our specialties evolve and lines are blurred, we also need to make sure that our training does too. For example, cardiac surgery is moving towards a hybrid approach, so we should be exploring concurrent training with vascular surgery or interventional cardiology in this country, but we're not quite there yet. Private practice is also another area to employ our specialists, but it has a bad reputation as being quite an unsupported environment for the younger fellow, for the new practitioner. But we should look to create private units that mimic our public ones so that our new specialists can work in a much more supported environment. And finally, maybe we need to take the step of restricting training numbers, both of medical students and specialists, if this does expose itself as being a really difficult problem. In the UK in the early 2000s, there was a moratorium placed on cardiac training as they had an oversupply. And with any uncertainty, it's not unreasonable to ensure that our people in our society get the most from our specialists. This is a really complex and evolving problem, but I think if we don't start to at least address it now by looking at it, we're going to be in a very, very big mess in the future. Thank you very much.